In this session, we will consider disorders of hemostasis. At the end of the session, you will be able to list the common conditions affecting hemostasis according to the classification that we discussed in our last talk. So we'll be looking at vascular, platelet, and coagulation disorders. We will also discuss the pathophysiology and clinical features as well as the management and investigation of selected conditions. So when we're thinking about conditions affecting hemostasis, we can look at these vascular, platelet, and coagulation disorders as some of the more important conditions that you might encounter in an emergency department. For your Part 1 exam, the conditions highlighted in red are some of the conditions that you should focus on and learn a little bit more about. Of course, the drugs are always important, those listed here, plus others, such as the thrombolytic agents. In this lecture, we will focus in some detail on the conditions listed in blue. It's not that the other conditions are not important, but these conditions share some clinical features and pathological characteristics. So this is our first case. You can pause the video and read the clinical vignette, after which try to formulate a main diagnosis and a differential. Here's a picture of the child's legs. Again, see if you can tie that in with the clinical picture. So, this is a case of Henoch-Schönlein purpura. Henoch-Schönlein purpura is an immunoglobulin A associated vasculitis. It's often post-viral, affecting mostly children, and is characterized by purpuric skin lesions, particularly in the dependent areas of the body, polyarthritis of the large joints such as the knees, ankles, hips, elbows, or wrists, colicky abdominal pain, hematuria or proteinuria, and fever. All of these conditions are associated with the vasculitis in these various organ systems, which cause the symptomatology. HSP is usually a clinical diagnosis, but we may do some investigations to rule out other diseases or to identify possible complications. So, for example, we'd look for proteinuria and hematuria in our urinalysis. We can do a blood count, RFTs, and abdominal imaging. And in cases in which the diagnosis is not clear, we may think about a skin biopsy. Treatment is mostly symptomatic. Steroids may help to reduce the symptoms of arthritis and abdominal pain, but do not affect the overall clinical progress of the condition. Most patients resolve within a few weeks. Many will recur at least once, but most children eventually resolve. Complications are rare and may include nephritis or intussusception. Case 2 is a 5-year-old female with bleeding from the gums for 3 weeks. This is her blood count. Again, pause the video and see if you can come to a diagnosis. So this is a picture of immune thrombocytopenic purpura, or ITP. It's an autoimmune disorder characterized by destruction of platelets and leading to thrombocytopenia. These patients, after a prodromal viral illness, may develop IgG antibodies against platelet surface glycoproteins. Once the IgG attaches to the platelet, it is then destroyed in the spleen, leading to thrombocytopenia. Again, the investigations are mainly to rule out other causes, so we might do a blood count and blood film, and in selected patients we may consider HIV serology, antinuclear antigen, a Coombs test, particularly if the patient is anemic and we think it might be hemolytic, imaging studies, and bone marrow biopsy in rare cases. Treatment consists of corticosteroids, anti-Ro immunoglobulin can be given IV, and of course we have to provide supportive care. You should limit platelet transfusion. As this is an autoimmune condition, any platelets given will also be destroyed in the body. In patients with chronic ITP, splenectomy may be an option. In case 3, we have a 5-year-old boy with swelling of the face and feet 1 week after recovering from gastroenteritis, in which he had fever and bloody diarrhea. His hemoglobin is 6.6, his platelet count is 43, and his blood and creatinine levels are elevated. You may want to pause the video here and have a go at coming up with a diagnosis. What does this film show? Well, what you're seeing here are abnormally shaped red blood cells of different sizes. So you have anisocytosis and poikilocytosis. In addition, there are very few platelets. This is hemolytic uremic syndrome. It's a clinical syndrome characterized by progressive renal failure associated with microangiopathic hemolytic anemia and thrombocytopenia. It's usually triggered by gastrointestinal infections, and the mechanism is that sugar toxin is released by the organisms, which then binds to the endothelium of, for example, the kidneys, producing an inflammatory response and a thrombotic angiopathy. Clinical features will include the prodrome of fever and bloody diarrhea, acute kidney injury leading to edema, hypertension, and anuria, and hematological complications such as hemolytic anemia, thrombocytopenia, and hemolysis. Investigations would include urinalysis, blood count, renal function tests, and also investigations for hemolytic anemia. This is a microangiopathic hemolytic anemia, but we need to rule out autoimmune causes, so we'll do things like the Coombs test, liver function test, and of course we can do stool cultures to see if we culture the offending organism. Treatment is mainly supportive. The evidence for the efficacy of other treatments is not conclusive. Case 4 is a 35-year-old female patient brought to the ED with a generalized seizure. She has been complaining of fever and lethargy for 2 weeks. She's pale, bleeding from the gums, and urinalysis shows blood 3+ and protein in the urine. This is her blood count. Again, you may wish to pause the video and see if you can work out what's going on with this patient. This is a case of thrombotic thrombocytopenic purpura. It's a rare blood disorder characterized by clotting in small blood vessels resulting in a low platelet count. The patients develop large multimers of von Willebrand's factor, which cause aggregation of platelets and intravascular microthrombi. It's really an autoimmune disease. The antibodies inhibit a protease which specifically breaks down these multimers, causing them to aggregate and then attract platelets, leading to microthrombi. So the clinical features include the classic pentad of microangiopathic hemolytic anemia, thrombocytopenic purpura, neurological abnormalities, fever, and kidney disease, although all these features may not be present in any one patient. Investigations include blood such as blood count, clotting screen, FTPs, D-dimer, RFTs, urinalysis, and hemolysis screen. It's important to note that this battery of tests helps to differentiate HUS, TTP, and DIC. So in TTP, the patients usually have a fairly normal renal function and normal to normal high levels of FTPs and D-dimers. They do have the hemolytic anemia plus the thrombocytopenia. In HUS, there's a similar anemia and thrombocytopenic purpura, but the RFTs are abnormal, while the FTPs and D dimers, like in TTP, are normal to high normal. For TTP, the treatment is plasma exchange or supportive therapy. Our final case is a 78-year-old man, 1 week into his COVID-19 diagnosis, brought in with bleeding gums, hematuria, and pulmonary hemorrhages. And his hematological workup reveals a microangiopathic hemolytic anemia with thrombocytopenia and elevated D dimers and FTPs. So this is DIC, or disseminated intravascular coagulation, which is characterized by systemic activation of blood coagulation resulting in deposition of fibrin leading to microvascular thrombi and multiple organ dysfunction syndrome. Consumption of the clotting factors may also lead to life-threatening hemorrhage. In this condition, a variety of severe illnesses can cause a systemic inflammatory reaction or activation, and specifically tissue factor-mediated intravascular thrombosis. In addition to depressed anticoagulation and impaired fibrin removal, this combination leads to a depletion of clotting factors and a bleeding tendency. So the patient presents with the features of their precipitating condition plus bleeding and intravascular coagulation plus multiple organ dysfunction. The investigations are as for TTP and HUS. These patients tend to have the microangiopathic hemolytic anemia with thrombocytopenia and high levels of D dimer and FTPs, which puts it apart from TTP and HUS. There are DIC scoring systems that can be used to help in the diagnosis. On the next slide, I'll show you what. Treatment is really treatment of the underlying condition and supportive care. So this is a diagnostic algorithm for the diagnosis of DIC. You may wish to pause the video and look over this in more detail. You don't need to know this in great detail, but it's good to know the kinds of factors that make up this scoring system. So that's our very quick talk on hemostatic disorders. If you have any questions, you can bring them up in class. In summary, we've looked at conditions affecting hemostasis, dividing them into vascular, platelet, and coagulation disorders.